Good afternoon. I am a ratified member. My membership number is S11035. Good afternoon. I am here to present our work on the response of retinopathy of prematurity to anti-VEGF. So lasers are the gold standard for treatment of ROP, but the BEAT ROP trial established the use of anti-VEGF in ROP and is mainly indicated for posterior disease. Borrowing this image from the BEAT ROP publication, if we look at the lower image where the baby has received Avastin or in this trial bevacizumab, we can see that the vascularization is seen to progress to the periphery over a period of time, whereas the upper image where the baby has received laser, we can see the scarring and destruction of the retina due to laser treatment, which in very posterior disease can encroach on the posterior pole as the eye grows. Our case is a retrospective case series of babies screened for ROP at our institute between January 2013 to December 2017. For all the babies amongst these who received bevacizumab, we noted the risk factors, zone and stage at injection, and the timing and need for laser. Our treatment protocol was when a baby was diagnosed to have aggressive posterior retinopathy of prematurity or staged ROP, that is type 1 ROP in zone 1 or posterior zone 2, they received intravitreal bevacizumab at diagnosis or within 24 hours. We followed up these babies till the retina was mature. We gave them laser if they developed treatable ROP or if the retina failed to mature at around 55 to 60 weeks post-menstrual age. This is the injection procedure was we injected both the eyes at the same sitting, half dose 0.03 ml, 1.5 mm for limbus. But though we did both eyes in the same sitting, we did them as two separate procedures with separate speculum, drapes, and all separate aseptic precautions. In this time period, we screened 1,957 babies, out of which 60 eyes received bevacizumab, 34 for aggressive posterior ROP, and 26 for staged ROP. Of the AP ROP, 18 went on to be mature, 4 needed laser for treatable retinopathy, and 12 prophylactically. In the stage group, 12 became mature, 10 needed treatment laser, and 4 needed prophylactic laser. If you looked at the baseline characteristics of these babies, for the babies who needed laser in addition to injection, they had a lower birth weight, but this was not statistically significant. Their gestational age, they were younger. They received the injection at a younger post-menstrual age. This both was statistically significant. The interval between the injection and laser was about 112 days. Coming to the discussion, anti-VEGFs are a simple and quick treatment as compared to lasers for ROP, and they help vascularization progress to periphery and are non-destructive. There's lesser progression to detachment, macular ectopia, and also a lesser occurrence of refractive errors. The disadvantages mainly are the need for a prolonged follow-up and concerns about late recurrence, which can be as late as 55 to 60 weeks post-menstrual age. There are also concerns about systemic complications due to use of anti-VEGF in these premature babies. A large cohort from the BEAT ROP itself showed that these babies had no related systemic complications, but there are also numerous reports in the literature about the same, and so the jury is still out on this point. Why did we do prophylactic laser? So what happens is when the baby is about 55 to 60 weeks, they become big, and it's very difficult to examine the periphery in an OPD setting. And there is no evidence so far as to what happens to a residual avascular retina left in the periphery. And hence at around this age, we prefer to do an examination under anesthesia and give laser prophylactically if we find any avascular area, which is usually very minimal and very peripheral. So what does our study bring us to? There is no need for simultaneous anti-VEGF and laser. 50% vascularized completely. Of the 50% who need laser, 27% need minimal peripheral laser, and only 24% have recurrence, which is much lesser and much more peripheral. Babies needing laser have lesser birth weight, lesser gestational age, and they need injection earlier than their other cohort. The drawbacks of our studies, it's retrospective nature, and there is no imaging data. So points to note is anti-VEGF monotherapy with monitoring has good outcomes. Laser can be deferred and delivered as needed. Prolonged follow-up is an inconvenience, but this can be overcome with good parent counseling.